I would like to thank Professor Chaudhary, Professor Jamal, Professor Azam for inviting me in this prestigious conference of Bangladesh. Now, I would like to talk on the very complex topic. There is a left vein intervention in a calcified vessel. So, how should I treat? Now, left vein is always a challenging subset, and even significant calcium burden makes it a more difficult subset, because if you cannot prepare the bed properly, and if your stent deployment or stent final result is not very satisfactory, then always there is a chance of immediate or short term or even complication, and that can be fatal. So left main bed preparation, stenting, they are very important. There is very less margin of error in the case of left main intervention. Now I am going to present my case, rather two cases. So this is a 82-year-old fragile gentleman. He is very fragile, BMI only 18, weight 40, 45, T2DM. He has a recently PTCA stenting to LAD, but unfortunately the patient again came to our hospital with unstable angina. He has an ejection fraction of 50% with inferolateral scarred, akinetic, probably infected area, and other walls showing normal contractility. Now, this is the angiogram I would like to share. Yeah. So this is a angiogram. So in the cranial view, in the caudal view, you can see the stent is placed in the proximal part of the LAD, and the proximal part of the LAD stent have a significant ISR. Not only the issue ISR, but you can see the disease started from the left main, and the rail tram track calcium with a chunk of calcium you can appreciate from the angio alone. So this is a very complex issue. The RCA is very diffuse, and circumflex also is very diffusely diseased. I think it was an infected area at that time. So basically, we are dealing with a very complex lesion post PTCA and severe left main calcium, and practically the single surviving artery, I think. So left main is the only artery, but other supply is very poor or nominal, minimum. So we have to plan the patient. So whether to go with the PCI or CABG, definitely with the 82 years fragile elderly male patient. Yes, both me and your patient party, they don't actually agree or to send the patient to the CABG. And number two, the imaging. Imaging is essential to what should be our strategy, how to modify the plaque. So imaging is very important in this case. High calcium burden, plaque modification, whether you use a coding balloon or cutting balloon or rota or IVL. So that is the question of discussion, and how you should proceed in this case. So I just put a 2 millimeter balloon, gentle dilatation, to make a passage so that I can actually use my IVAS catheter. So this is the IVAS run, and it is a very interesting to see what is the IVAS now. Can I actually make some forward movement of the IVAS? Yeah, this is the distal part of the stented area of the LAD. Distal part is overall okay, but the issue is that when we gradually come in the proximal part, where is the main lesion, that is the ISR, then we can appreciate there is a calcium nodule in the stented part. So this is the calcium nodule. So this is the IVAS run. Now this is one of the nodular calcium in the stented part. You can see this is the nodular calcium and projecting in the lumen. Now as we coming to the left main area, this is the left main. This is the left main area, and in the left main area you can appreciate there's a two chunk of calcium. There's a two nodular calcium. One in this is the superior surface, and one in the inferior surface. So you can appreciate what is the significant calcium burden in this in this case, and these are very tough cases because this large calcium nodule, they are very resistant to your normal scoring or this cutting balloon. And also, this rotational atherectomy, they are very useful when there is a concentric your calcium and the thickness is less. But in a case of deep-seated calcium, a chunk of calcium is a thick calcium, the rotational atherectomy is not very suitable. So you can see this is chunk of nodule in the superior surface and the inferior surface. So in this case, we choose for this shockwave lithotripsy, and we choose a 4 millimeter balloon for this case. Now, this is the short description of the shockwave lithotripsy. There is a 12 millimeter balloon, and there are two lithotripsy emitter. Now, this lithotripsy emitter emits the electric spark, and there is a fluid inside the balloon is vaporized, and there is a expanding and collapsing of the bubble, and they create a sonic pressure wave. Now, this sonic pressure wave create a acoustic energy that travels through the vessel wall, and they fracture the intima and the medial calcium. Now, they allow the vessel compliance and optimize the stent expansion. So, this is the IVL. This is the 4 millimeter IVL. Now, the problem in the IVL in this particular case is that as it is a only single survival artery, it is very difficult to inflate the balloon for 10 seconds, because 10 seconds is required for each pulses, 10 pulses. Now, it is very difficult to keep the balloon inflated in the left main for the 10 seconds. The patient at that time having recurrent symptom of hypotension, and we have to manage by giving your ADR and non-ADR. So these are very challenging, particularly in this case, to put a IVL balloon for 10 seconds. And even after repeated inflation of the balloon, we cannot achieve very optimum result. You can see there is still some wasting in the inferior surface. There is still some wasting in the inferior surface of the balloon. So you can appreciate how tough the calcium in the left main this case, that even after repeated pulses, we cannot achieve a very good result in this case. Now this is the repeated pulses given, and it is a result what we can achieve after this 8 times inflation. That is the total 80 pulses. So this is the our achievement. So we are not very satisfied. Then we decided to take again an IVL, again IVAS at this stage. Now this is the pullback IVAS run, and I have this is the left main portion of the calcium where there is a 2 nodular calcium. Now you can see that in the inferior surface there is a linear calcium and there is a no crack. So inferior surface there is almost no modification of the plaque, but definitely in the superior surface you can see there is some cracks have been created. So at least we have achieved some result after doing this IVL. And after that we give a scoring balloon. It's a 3.5 millimeter scoring balloon to a very high pressure. They are basically NC scoring balloon, and you can go up to 30 millimeter. So we try to put the balloon as a very high pressure at that, so we can achieve more good result during in terms of bed preparation. And after doing that, we put a stent. Stent expansion is not very bad from angiographic view. And after the stent placement, this was the result. So we did a pot. It is a 4.5 millimeter balloon, and did a left main proximal optimization. And after left main optimization, we give a 3.4 millimeter NC balloon in the LED stent, and give a very high pressure dilatation. And after that, ultimately we can achieve such a result. Though in the AP, in the cranial view, in the there is some the stent expansion is not very optimum, but in the yellow caudal view you can see it's a good expansion, I think. And we did a again we did a IVAS to see what is the ultimate result, whether we can achieve a good area or not. So this is the IVAS run. final IVAS run. Now you can see in the LM, there is definitely a good stent apposition, and the area in the LM where there is a significant calcium burden was more than 10 millimeters square. So it is almost 11 millimeters square. And in the proximal LAD, we have achieved almost 10 millimeters square and without any malapposition. So by definition, this result should be taken as a optimum result, because there is no under expansion. We have achieved a good luminal area at the end of the result. And I think in this case, it is better to accept this result because more vigorous something, which even we can try, it can create some complication at this stage. But with this good luminal area in the both LM and the LAD ostium, I think we should accept this result. So this is another, my second case. This is a 75-year-old gentleman, diabetic. He has a high-grade angina and a normal ejection fraction. So the angiogram was done in outside, and I don't have the angiogram CD, but we have taken the case for the LM plastic, and you can actually appreciate there is a significant distal LM disease, and the disease also progressing in the LAD proximal part with a significant calcium burden. The one thing is that the circumflex in this case there is no disease in the ostium of the circumflex. So in a tram-track calcium, we actually we decided to go with the straightforward with the rotablation. It is a 1.5 millimeter bar, and with gentle peking movement with the rotational speed around 1,50,000, we gradually able to cross the lesion with this 1.5 millimeter bar. And after this rotational atherectomy, we have a IVAS, and to look what is the what is the result of this your rotational atherectomy. So this is the IVAS, and in this picture you can see there is a crack in the superior surface of the calcium. Definitely there is a more than 2/3 arc of the calcium, and there is a calcium crack in the around 11 or 12 o'clock position. There is a significant crack, and after that we give a NC is a scoring balloon, is a 3.5 millimeter scoring balloon, and NC scoring balloon, and go to a high pressure around 20 to 24 atmosphere. And for the left main, we use a 3.5 millimeter scoring balloon, and I was very happy to see the expansion of the balloon. You can see the balloon is fully expanded, so lesion preparation was satisfactory from these views. Now rest of the procedure is very straightforward. Just put a stent from the left main to LAD. It was a provisional stent strategy because there is no significant disease in the circumflex ostium. After proper stent placement, I did a pot with a 4.5 millimeter balloon, and this was the and distal post dilatation with a 4 millimeter balloon, and it's the final IVAS. Showing a significant good result in the LAD proximal part. It was almost 8.5 millimeter square, and the left main, it was the area achieved was almost 12 millimeter square without any malapposition, and so this was a acceptable and the good result to my opinion. And so this is the final result. Now to summarize, calcified lesions are always very challenging, particularly plaque modification is very important, and in case of left main, it is more important because you cannot put a stent which is under expanded in the left main. Otherwise it will create problem in the form of ISR or stent thrombosis. So, and left main stent thrombosis is very fatal, almost 100% mortality. So margin of error is very minimum in case of left main. You have to prepare the left main very well for the stent deployment, and you have to use your scoring balloon, cutting balloon, your rotablation, your IVL according to the imaging and according to the case merit of the case, and individualization of the cases is required. There is no blanket statement. Some cases IVL may be suitable, some cases Rota can be a suitable option. So that can be decided on the IVAS, your result and the imaging results. And obviously, in some cases, when there is a very compromised LV function and the left main is a single surviving artery LAD, so that cases hemodynamic support may be taken upfront so that you can avoid some complications. Thank you very much for your patient hearing.